Good morning, dear ladies and gentlemen. I would like to invite you on a journey in the contemporary implant dentistry and its parameters with an innovative implant system. As you know, and as you feel, the time passes by, our patients have higher and higher expectations from us, implant dentists. They would like to have more and more minimally invasive procedures, maximal aesthetic result, not only on single implants, but also in adjacent implant situations. They would like to go home with fixed reconstructions in the first session of their treatment and to have a long-term maintenance on the reconstructions. So in all the cases which we did in the last 25 years with modern implant designs in immediate placement, immediate loading procedures, we had a high success rate of the osseointegration. And this statistics is the same as you can find in other studies regarding immediate placement, immediate loading, full arch reconstructions on implants from Karl Misch, Deborah Schwartz, De Guidi, Piattelli, and so on. That means that respecting certain parameters, coordinates, algorithms of implant placement, implant design, and prosthetic reconstructions, you have high success of the results. And this happens although we start with very compromised bony and soft tissue situations, and we reestablish this aesthetic and function with a long-term maintenance also on adjacent implant situations, having and achieving quite good aesthetic results. One of the examples of the freehand surgery in full arch reconstructions is this one, a case which was done maybe 10 years ago, in where the aesthetic design of the teeth was visualized in a Keynote software, and the provisional was made in advance and placed on the primary stable implants in the same session. Patients went home, and after the integration of the implants, the individual abutments were done with certain parameters and certain designs, which we will talk about later on. Long-term result is that using certain designs of the implants, we see a stable bony and soft tissue situation of this case on the long run. Now, the topic of the presentation today is to make a summary of these algorithms, parameters, which we know, and we don't know everything, but to sum them up and to see which parameters are study-based, make our treatment predictable, increase the rate of predictability, and give us a long-term result in aesthetic and functional reconstructions. So those algorithms which we have based on studies, literature, and experience are concerning the planning, the implant design, the implant position, the bone grafting, the soft tissue dimensions, the surgical philosophy, surgical way of doing the incision and the flap design, the prosthetic design, and all this can be, of course, implemented in a digital workflow with its advantages and maybe disadvantages, and a long-term functional and maintenance, where we have also parameter for. So let's go through all these parameters, beginning with aesthetic planning until the final reconstructions. The moment a patient steps into our office, and we start the planning, we have to take into consideration the necessity of increasing the occlusal vertical dimension. This will give us the crown height space which we have to disposition in order to reestablish the crown of the restoration. And we can make this classification in FP1, FP2, FP3, depending on the crown height space. In a Frick's prosthesis 1, the crown height space is between 8 and 12 millimeters. This is the situation when the patient comes with maybe not quite teeth not to be maintained, to be extracted, and to do an immediate placement, immediate loading. And it's the most predictable aesthetically seen. The FP2 situation is where the crown height space is between 12 and 15 millimeters. Those are the situations where it's a perio patient, we extract the teeth, we have a little bone loss in the vertical dimension, and might be that we need a longer teeth, or the teeth will be more inclined, or maybe we have to add a small pink component in order to reestablish the profile of the patient. FP3 is the situation where the patient comes edentulous or partially edentulous, is the situation where we probably will need a bigger pink component in order to reestablish the profile of the patient. These dimensions and these parameters, this rough planning is starting with the first session, and it is clear in the moment we make a mock-up of the patient. Of course, another parameter is the implant design. Since we know that implant design plays a very big role in the stability of the bone and the soft tissue, in the capacity of doing an immediate placement of the implant and an immediate loading. That is why we use modern designs which have some very well study-based features in order to give us the most predictable result in a primary stability, in the aesthetic possibilities, and in the long-term stability of the bone and of the peri-implantary structures. Already in 2007, we saw that, together with a group of clinicians, that there are some factors in the implant design which might influence the stability of the peri-implantary tissues. And we use since then only those implants which have these features because they help us in our target of our full arch reconstructions in immediate placement, immediate loading procedure, and targeting to a good aesthetic outcome. We know that every implant system can be successfully placed if the clinician is aware of the features of the implant. But it is a consensus also that the initial stability is beneficial to be able to do an immediate loading, that a platform switching design is the one, and this is documented in the literature in 300 articles, the one capable to maintain the bone around implants, to decrease the bone loss from 1.5 to 0.4 millimeters, and also to maintain the soft tissue situation around implants. There is also a consensus in the literature that a very stable connection, whereas the more tapered conical connection seems to be the more stable based on the literature, in order to avoid micro movements, avoid the bacterial pus from the internal life of the implant, to avoid screw loosening and all the other complications which may occur with an other less stable connection between abutment and implant. Last but not least, a concave emergence profile or a running room will give us an added value of the implant and of the abutment in maintaining the soft tissue color and the connective tissue quality around implant and abutment, and we will see it later on. So the implant design, which had a rough surface to the collar, is placed sub crestally, 1 millimeter below the bone level, in order to allow the remodeling of the bone, which occurs already with a tooth extraction or the removal of the periosteum. A beveled collar will give the possibility the bone to smoothly grow distance-wise to that beveled collar. The implant most of the implants have a micro threading in the collar part, because biomechanically seen, and this we can read in the Contemporary Implant Dentistry of Carmich already, has less damaging effect on the cortical bone, which is less vascularized. So those forces, shear forces, which are transmitted to the bone are transformed in micro compression and traction forces, which are not damaging for the bone. The cortical bone needs to be protected from high forces in order to avoid resorption, which would occur when high forces will happen. Now, the body of the implant has a very aggressive thread design, which is meant to increase the ease of the insertion of the implant in the rest of the bone. Aggressive threads are okay for the spongious bone, and an additional thread and groove groove will help the surface of the implant to be bigger, and also the osseointegration to be better in the spongious bone. We have 3 different designs along on the body of the implant, based on the study coming from orthopedics that shows that the screws, the hip screws, for example, are much more stable if they follow by the design the different densities of the bone. This is an application in our field. The apex is aggressive until the tip of the implant in order to facilitate the insertion of the implant in the extraction socket, and the tip of the implant is round in order not to damage important anatomical structures or to cause bone parts which can damage the nerve in the mandibular canal, and also to be protective in the sinus region by the membrane. The collar of the implant has a cold weld seal. That means the Morse tapered conical connection, which we mentioned before, is the connection which this implant have, which avoids the micro movements. It's all based on literature. Avoids the micro movements, is like a cold seal coming from the aviation industry. The gap is smaller than a bacteria, and is not allowing, therefore, the pus from the internal life of the implant to get out in the mouth cavity, and the other way around. This connection is also avoiding the screw loosening. So we have statistically 0.37% screw loosening of the implant, and also the literature shows the highest stability in the bending forces, in the shear forces on the implant. So practically between the abutment and implant there is no gap. Practically, microscopically, is no gap. Of course, we have an indexing hex. Prosthetic parts of the implant will have an hex for indexing. There are also parts which are not indexed for the rotational, anti-rotational stability of the parts. The surface of the implant is, of course, facilitating the osseointegration through a micro and nanostructure made by acid etching. And what is very important is the cleanness of the surface. Many implants have rests of metal rests on the surface, and one of the studies made in the University of Cologne showing the quantitative and qualitative element analysis of the implant surface on electronic microscope shows that this implant, that aesthetic line of C-Tech implant, has no inorganic or organic residues and high mechanical precision, which is very important, not only for the osseointegration, maybe it's not influencing the osseointegration generally, but those particles are for sure not to be consisted in the human body. Now, in one of the studies which we did on this implant design regarding the bone stability and aesthetic benefits, using not only the features of the implant, but some of the surgical and techniques and materials for grafting and for implant placement, we had very good results concerning the bone loss, which was 0.5 millimeter in 90% of the cases. We had a very high success rate only with this implant system. We had a high pink aesthetic score, soft tissue thickness, which was more than 1 millimeter in 90% of the cases, and a width of the attached gingiva of more than 3 millimeters in almost 90% of the cases. As I said, not only using by this implant design, but also some other algorithms of bone and soft tissue dimensions and techniques of grafting, which are minimally invasive and are proven in the literature to increase the quality of the bone, the quality of the soft tissue, and the prosthetic design. So what about the implant position? Now, we know that the positioning of the implant is a key feature, a key proportion or algorithm to give us a certain predictability of the aesthetic of the implant or of the result. So we know that the distances between the implants has to be 3 millimeters, the distance to a neighbor's tooth 1.5 millimeters, that the depth of the insertion is 4 to 5 millimeters from the free gingival margin that we want to achieve, and also the 4 to 5 millimeters from the most buccal contour is important. And this anterior posterior distance is including a gap which has to be grafted and a certain thickness of the soft tissue. So studies are showing that if we respect this 4 to 5 millimeters in the positioning of the implant and we take care of the bone grafting or of the bone thickness around the implant and the soft tissue thickness, we can have a very good result also on the long run. On contrary, if these results, if these parameters are not respected, we might have an aesthetic compromise because the prosthetic solution will not forgive these discrepancies. Also, the implant axis in the extraction socket seems to play a role in the treatment outcome and also in the choice of the prosthetic parts used. Whereas years and years we thought that if we don't have the screw palatally in the prosthetic construction, we are not that good surgeons. We know today from the study of Joseph Kahn that 80% of the anatomical situations are allowing an axis of the implant where the screw is buccally. And only 1 to 2% of the situations, now class 3, are the ones where allow us a screw palatally in the frontal region. That means that either we take care of the quality of the soft tissue and a prosthetic design and the parameters of the abutment in a way that it allows us a cementation, a paragingival cementation of the crown, or we take care that we use prosthetic parts which allow us to move the screw palatally, like a tilted screw canal or a multi-unit abutment for single tooth in order to move the screw palatally. So Also, this choice is to be considered in the planning of the construction. So as I told you, if the parameters are not respected, we can have a static compromise of the tooth by tooth reconstruction. That is why digital planning of the implant and implant navigation or navigated implantology seems to offer us a better possibility, a more controlled placement of the implant with static parameters. And that is why digital implant dentistry is the present, not even the future. But let's go back to the normal parameters. Bone, the peri-implantary bone, which we need to have, is an important parameter also in immediate placement of the implant. Because we know also from Joseph Kahn that we tend to have and we need to have that 2 millimeters of bone around the implants. And this has to be grafted inside the socket or outside the socket. So inside the socket by immediate placement. But if we don't have that bone, then we have to open the flap and graft the bone to the 2 millimeters, which we tend to have. Now, in immediate placement and immediate loading, we have certain parameters of insertion. All implants has to be primary stable. And in order to load the implants in the immediate placement procedure, those implants has to have also other criteria mentioned by Tarnow, described by Tarnow in his article. The immediate occlusal loading conditions are, in the implants inserted in the immediate socket, are initial stability, 3/4 of the implant surface should be covered by bone, the gap should be grafted, the provisional should be splinted over all initial stable implants, and the occlusion should be in harmony, balanced occlusion. So all these are conditions which has to be respected for a successful immediate occlusal loading in immediately placed implants in full arch reconstructions. What about the soft tissue parameters? Now, we know that the soft tissue which has to be maintained around implants have to have different certain parameters. How much soft tissue do we need around implants for predictable, stable aesthetics? This is the question. We know that when after the tooth extraction, we have a different biological environment around implants, different behavior, because we don't have the vascularization from the periosteum. We have no periodontal space. We know that after the extraction, the bundled bone with the periodontal ligament investment loses its function and disappears after 2 to 4 weeks. We know that after 6 months, we have a horizontal bone loss which can go until 60% and a vertical bone loss until 20% if we don't graft the socket or we don't place immediately an implant. What else do we see in the literature is that there is a difference in the behavior in an immediate implant placed in the extraction socket, depending on the tissue biotype. If we have a thin biotype, we have a 1.8 millimeter marginal recession, whereas in a thick biotype, we see an average of 0.6 millimeter marginal recession after immediate implant placement. We see also after 1 year of function and immediately place implants in the extraction socket, a difference in the bone behavior. So we have only a 0.2 millimeter bone loss in a thick tissue biotype and 1.45 millimeter bone loss within the first year of function in the thin tissue biotype. That means that our surgery is tissue thickness oriented, and we have to have a certain, or to maintain or to achieve a certain soft tissue thickness in order to assure and to avoid the bone loss, and to assure a certain maintenance of the volume of the bone and of the volume of the soft tissue. So, and these parameters should be respected independent of the implant design. We see in the literature that if you have less than 2 millimeters of tissue thickness, horizontal soft tissue thickness, we lose 1.5 millimeter of bone. And if that collapse is more than 1 millimeter, we see those discolorations. So that means the conclusion is, if you have more than 3 millimeters soft tissue, horizontal tissue thickness, we don't have bone loss. It shows if we lose only 0.1 millimeter of bone. Linkavicius shows us that even if the implant design has a platform switching feature, we still lose bone if the tissue, peri-implantary tissue, is thin. What about the soft tissue height? Now, we talk also about the depth of the insertion. And the depth of the insertion, as you heard before, is 3 to 4 millimeters from the free gingival margin that you want to achieve. And this is actually the height of the tissue which we'd like to achieve, also in order to avoid collapse when the margin is slightly paragingival, slightly subgingivally, and also to assure the possibility of doing and of having a papilla between two adjacent implants. Now, this tissue height dimension was mentioned by Gargiulio already very long time ago, where he showed that after the uncovery of the implant, where the soft tissue was 4 millimeter height, had a 4 millimeter height, after the uncovery of the implant, a biological width will be built. This biological width will have also around 3 millimeters, and everything will be stable, stay stable, because the height of the gingiva is 4. Now, on the right side, you can see a 2 millimeter tissue height. After the uncovery of the implant, a biological width will be built like a scar every time. And this biological width will have 3 millimeters based on the 3 parts, histological parts, which we know. And this biological width will be built on the cost of the bone loss, as you can see with a blue arrow. So already then it was clear that we need a certain height of the soft tissue in order not to lose the bone, to avoid a bone loss, but additionally to give us the volume necessary to build up a papilla between two adjacent implants, if it's necessary. Do we need keratinized gingiva? For the stability of the implant, not necessary, but the keratinized gingiva, and we can read it in the article of John Coyce, is needed around the implant to protect the implant against infection, against recession, to protect the implant against inflammatory procedures and processes, and it's giving a stability of the soft tissue situation. Now, we need that 3 millimeter tissue, keratinized tissue, if the height of the tissue is there. If the height of the tissue, peri-implantary tissue, is 3 millimeters, this tissue will be keratinized. So as a consensus or as a thumb rule, we can say we need 3 times 3 millimeters around implants, 3 millimeter tissue thickness, 3 millimeter tissue height, and 3 to 4 millimeter attached versus keratinized gingiva around the implants. Sometimes we have this situation, we have this nice tissue around implants, and everything that we need to do is a minimally invasive procedure without raising the flap, maintaining the tissue, and treating it accordingly. Now, if we don't have this tissue, what is the procedure that we have to do? And this is the second take-home message, is to measure the tissue thickness in the moment of the first surgery. if this surgery is an immediate, is a placement of the implant, is the grafting, or is a simultaneous placement of the implant and grafting, we need to measure the tissue thickness and the soft tissue biotype, and to increase the soft tissue thickness in the moment of the first surgery. Now, how should we do that? Because in a single tooth reconstructions is easy to do an connective tissue graft, and we insert it in an envelope technique or a tunneling technique, a pinhole technique, minimally invasive, and increase the soft tissue thickness. Nevertheless, in full arch reconstructions will be more difficult. That is why we saw and we started to use matrices which are out there and in the market, and which are proven to increase the soft tissue quality and the soft tissue thickness around the implant. That is why, based on studies together with the University of Frankfurt, with Goethe University and Professor Ganati, we started to do a study on 25 cases using 5 different categories and techniques of soft tissue grafting by PRF, by 2 other matrices on the market, which are prone and are proven to increase the soft tissue quality. PRF, as we know, and we don't go into that histology, but we know that PRF is not a membrane, is not a barrier. PRF is prone to increase the healing potential and the soft tissue quality. Is not used on the grafting material, it's used on below the soft tissue, and in the cases where we don't need any grafting. Whereas when we do an immediate placement, immediate loading, we use the matrices perforated by the rubber dam instrument, which will be placed on the provisional abutments. And we have cases where we use the membrane or the matrix and the PRF on the top of the matrix in order to see which is the soft tissue grafting amount of soft tissue gained after these kinds of procedures. And we measured with the histologies and measured the soft tissue thickness afterwards. So doing a perfect positioning and insertion of the implant in the extraction sockets, and having the need to graft the bone, we proceed in some situations and look at the position of the implant, the design of the implant. We place the implant accordingly and do the soft tissue grafting and the bone grafting in the same session by bone grafting material and matrix over the provisional abutments, and also perforating the PRF membranes on the top of those abutments. And doing those kind of cases in 25 full arch reconstructions, we saw in all these situations a better soft tissue quality than before. But we wanted to quantify and to see what kind of tissue we have there. Is that a connective tissue? Is that a stable tissue? Is that how are the membranes behaving regarding the foreign body reaction below the gingiva? And we had some conclusions regarding every category, which is submitted and will be published in the BMC Oral Health. So we realized that in categories with PRF, but also in the matrices grafted, with matrices grafted cases, and also in the cases with the matrix and PRF on the top of it, we had different increasement of the soft tissue quality and thickness. And this is meant to quantify and to make the soft tissue grafting more predictable around implants, which have a concave emergence profile and allows the maintenance, the increasing of the soft tissue and the maintenance of the soft tissue around it. Now, we tend to give the patient this fixed restoration in the same session. We tend to use implant designs which give us a good primary stability, and to do the grafting, as you saw before, in the same session, aiming to very good aesthetic results by very well defined bone dimensions and parameters and soft tissue parameters. Now, making a summary of all this, and we try to define the parameters of peri-implant aesthetics and also the techniques to get to the perfect aesthetic result in less sessions with a simultaneous implant placement and grafting. Now, as we can see in this graphic, we have a surgery, an immediate placement, immediate loading, which is tissue thickness oriented or tissue thickness driven. So that means that in a first category, where we have an ideal socket, we can do an immediate placement, immediate loading, but in thin tissue biotype, we will have to graft the soft tissue in the same session with a non-invasive method of grafting of the soft tissue with connective tissue graft or one of the matrices in an envelope technique or in a pinhole technique. In the group 2, as you see, we have a defect of the bone. In this category, we can place the implant immediately, or we can place an implant, and we graft in the same session by bone grafting, by a membrane or a matrix, in the case of the thin tissue biotype. But if the defect is at the color of the implant, then we tend not to load the implant immediately, but to close the site with one of the methods available, meaning an socket seal or an onlay graft from the tuberosity, which seems to be the most predictably aesthetically seen. When we don't have the buccal plate, or the defect of the buccal defect is more than 3 millimeters, Homely Wang describing a technique which is called the sandwich technique, covering the surface of the implant with the allogenic or human bone or autogenic bone, membrane, and a flap. So, or synthetic bone grafting, membrane and a flap. Now, we have today several other methods also, and we realize that even if we graft that defect with a mixture of 60 to 40 allogenic, autogenic bone and bone material, we will have in the immediate contact with the surface of the implant bone. In the fourth category, if we don't have interdental bone, and we have, let's say, a 6 millimeter bone height, then until 3 millimeter height, we can graft with particulate material and with different techniques which allow different parameters which can allow us to graft and to place the implant in the same session. Another option would be, of course, short implants with its pluses and minuses. So let's see on a concrete cases how we proceed. In the first group, by the immediate placement, immediate loading, we place the implant in a certain defined implant position in a way that 3/4 of the implant is covered by bone and the gap should be grafted. The immediate loading means, or immediate restoration means, the provisional abutment will be placed on the implant and a provisional crown which is not in occlusion. Okay. This is the grafting and the provisional abutment, sealing the implant site. This is a clinical case. The prosthetic part is a peak prosthetic part. You can see the connective tissue graft placed in an envelope technique, and this is the perfect soft tissue situation around the single tooth implant. And this is the final situation. If we have adjacent implants, we behave similarly. We use implant systems which give us a good primary stability. Look at the position of the implant between the implants to the teeth, to the buccal contour. immediate restoration with a provisional abutment with a concave emergence profile, a long concave emergence profile, which allow the soft tissue to grow and maintain the soft tissue around it. Graft the socket and graft the soft tissue, seal the soft tissue either with PRF or with matrices, which we mentioned before. And look at the soft tissue situation afterwards. Now, we know that the papilla between two implants, generally the gingival papilla appearance is depending on the tooth form and shape, the proximal contact length, the crestal bone height, and interproximal gingival thickness. That means that all these parameters we can control. We can guide the soft tissue gained by different techniques between two crowns. That means that the reality that we get a shorter papilla between two conventional designed implants changed today. We use implants with platform switching design, which gives us a less bone loss of 0.6 millimeters instead of 1.46. We have more supracrestal fibers, and we have also a non-surgical thickening of the tissues by the concave emergence profile. And those parameters can be used, and issues can be used in immediate placement and immediate loading with the provisional parts with a concave profile. Whereas when we do the final abutments, we can design the papilla between two crowns, between two implants, by the design of the final prosthetic parts. The final prosthetic abutments has to have an S-shape concavity, or that means they are concave in the immediate neighborhood of the bone and slightly convex to the contact point. The contact point between the crowns should be physiological. That means 42 to 45% of the intercoronary space, like Tarnow defined it in the natural teeth. And this triangle between the implantary crowns should be narrow in order to facilitate the designing and to matching that papilla, that soft tissue, into that space to the contact point. That means we have a higher or longer papilla immediately between two implants, respectively between two implant crowns, than we would have had in a conservative design of the implant and a conservative design of the prosthetic parts. So that is why we use implant systems which have features which are facilitating the aesthetic outcome in adjacent implant situations. And the S-shaped concavity of a transmucosal portion is giving us a firmer connective tissue barrier, which is maintained over time. This is documented in the literature. Now, of course, though all these parameters and procedures we used in full arch reconstructions, and one of the cases was published in one of the aesthetic dentistry books by Deborah Schwartz. This case was made, I think, 15 years ago. The contact point between the crowns is physiological, the triangles is narrow. You can see a slight compression which happens in the soft tissue when we insert the final individual abutments in an S-shaped concavity. The final result is really aesthetic, and this result we can see today also, this result which we did at that time, also after years and years. In the group 2, where we have a horizontal defect of the bone, of the buccal defect, as I mentioned in the classification, we tend, especially in the thin tissue biotype, to not to do an immediate loading, but to close the site after the bone grafting and the soft tissue grafting. We will seal the socket in the best well-known procedure or technique. One of the techniques, which is very predictable, is an onlay, sealing it with an onlay graft from the tuberosity after an ice cone technique of membrane grafting will be done. And this onlay graft has to be perfectly adapted, perfectly stable, and has to have a 1.5 millimeter distance to the neighborhood teeth in order to be able to have the vascularization from around, because we don't have the vascularization from below. After 7 years, this case looks very appealing, aesthetically seen, and it's stable over time. In the group 3 are the situations where we have even less bone in the buccal plate, and we have to use techniques which are maintaining the profile, the volume on the long term. So one of the methods which we use in a long time is the polylactid membrane welded on the bone, which has a resorption time of between 6 months and 1.5 years, maintaining its stability over all this time. This container of bone which we create is stable, and it will be filled by a mixture of bone, autogenic, allogenic bone with bone substitute, which has to have the necessary bone potential. In this case, when the implant is inserting and it has only 2-3 millimeters vertically bone loss, and this defect can be transformed with the membrane, with this plate, in a 3 bony wall defect, then this treatment can be done simultaneously by implant placement and grafting. So we need a defect which has a mesial and a distal bone peak. We do perforations in the cortical bone in order to assure the bone potential from the inside, from the spongious bone. We insert the implants with the condition that there are maximum 2-3 millimeters free and to be grafted. We transform this defect with a polylactid membrane, which is welded with polylactid pins into the defect, and we fill the defect with a mixture of allogenic, autogenic bone and synthetic bone in order to have enough bone potential there, covering with a collagen membrane, and we have this situation. In this way, we did simultaneous bone grafting and implant placement in many cases with a very good success rate on the long term, and the cases are 10 to 15 years old now. So the case which you saw before with the C-Tech implants placed in the immediate situation were done exactly after this procedure. We grafted horizontally and vertically the defects which we had in the compromised bony situation with polylactid pins, which are welded at first, and the polylactid membrane welded on the top of it. On the top of all this grafting will be a collagen membrane, which is perforated with a rubber dam instrument. The provisional abutments are peak abutments with a long or a high concave profile in order to allow the deep insertion of the implants. That is the provisional placed immediately after the surgery. And from the compromised bony situation, we created a stable bony and soft tissue situation, which is stable and time. Another parameter which we need to respect, and the technician needs to respect, is the 3 to 4 millimeter between the margins of the final abutments in order to assure the base of the papilla to grow. And this is the final result. So, of course, we have criterias of very well-defined criterias where to do a screw retain or cemented reconstructions. And we know that we did a lot of mistakes in the past by not considering the cement rests in the sulc or in the sulcus, which were near to the bone. And Linkevičius shows us in his study, in his article, that the cement in the sulcus is one of the main causes of peri-implantitis. That is why we have to choose our criteria. That means you saw the possibility and the necessity of having a certain gingival height around implants. If we have the 3 millimeter gingival height, we might be able to place the margin of the abutment or the preparation margin, the margin of the abutment paragingivally or slightly subgingivally in order to avoid the cement rests. Otherwise, if the soft tissue is thin and it stays thin, it's the screw retained construction is mandatory. So those are the criteria where we make our choice, tending, of course, in any case, to a screw retained construction as a priority. Now, how can the technician place the margin of the abutment in the model paragingivally? Now, that is a question of experience, of sculpting the silicone in a way that the soft tissue displacement is minimum and the margin of the implant crown is symmetrical to the natural margin. But for that, we have today in the CAD/CAM systems algorithms which the system can apply in order to place the margins of the abutment paragingivally or subgingivally in order to have the zirconia part of the abutment in connection with the soft tissue, because we know that the soft tissue has an affinity to the zirconia more than to IMEX, and those are the ways where how we design the abutment in the screw retained, but also in the cemented way. Now, I hope that I was able to share with you some of the parameters of implant placement, of the freehand implant placement, based on long-term cases, showing you that certain parameters of implant design, of implant position, of bone and soft tissue grafting, and of the choose procedure of the surgery can give you the possibility of fixed reconstruction in the same session and long-term maintenance. Thank you very much for your attention.